who advocated strongly when settlement arrived to advocate to continue their cultural traditions, cultural ways, and to look after and care for the Wadawurrung people of this land. I'd like to acknowledge Bunjil, our creator spirit, thank him for our creation stories, thank him for our creation law, and as part of creation law, we are all responsible for caring for country, land, water, and all things living. And that responsibility does sit with many of you. As care practitioners, as doctors, you will all, in your journey, in your time, provide care for Aboriginal people. So I'd like to also acknowledge all Aboriginal Torres Strait Islander people that may be gathered here today, and acknowledge Indigenous people for your cultural connection to your traditions and your cultural land and your people. I'd like to also acknowledge that this week, on the 21st of March, is Close the Gap Day. It will be a day where we'll ask for those conversations to take place, where we'll advocate and we'll hear about the gap of health between Aboriginal and non-Aboriginal people. Let's all walk together, cooling Wadanal, to close that gap for better health outcomes for Aboriginal people. I'll now like to welcome you all to the land with a welcome to country ceremony. Muan Bengadik, Kinkin Bill, Wedigarang Guli, Wavarang, Nalinguik, Kimbani, Wadawurrung Ja, Bunani, Dulama, Bengadak Ba, Gayupian Gulma, Muradop, Mukbari. In Wadawurrung language I say, from my ancestors, family and community, I welcome you all here on Wadawurrung country. Let us all come together, embrace each other and gather in peace. Kimbani, Wadawurrung Ja, welcome to Wadawurrung country. Yatni, thank you.
Thank you, Corinna. I would like to acknowledge the custodians of the land on which we're meeting today, the Wadawurrung people. Pay my respects to their elders past and present, and extend that respect to other Aboriginal and Torres Strait Islander people who are present. Please thank Corinna again for coming this morning. Thank you. This segment of our GP Refresher is being live streamed, and I welcome all those healthcare providers from across our region who've registered to watch our keynote speaker via their devices. So for just one moment, I need to do a housekeeping statement in relation to being in Geelong. So if the live stream people could bear with us for a sec. The bathrooms are through there and out into the foyer. This is a no smoking stadium. And if there's a fire or an emergency, the fire exits are in the trade foyer where you've just been through. But if the fire's there, we're going onto the ground. But the people here will be assisting us and directing us like on the aeroplanes. So I think that's the main housekeeping things. We plan to expand our live streaming as a communication medium as we go forward. For example, we've been made aware that the implementation of changes for the Quality Practice Incentive Program will now commence in August this year. Formal communication from the Commonwealth peak bodies and the PHN will be provided over the coming weeks, and Western Victoria PHN will provide more detailed advice on this and the implications for you and your practices over the coming months. So please stay tuned and access the live streaming as we go. It's now my very great pleasure to welcome our keynote speaker, John Macaskill-Smith. We are delighted that he accepted our invitation to talk with you today. John is the CEO of Pinnacle Ventures Limited, a New Zealand company that's on the cutting edge of innovation in primary health care. John has 20 years leading change in primary care, and he's passionate about bridging the gap between technology and outcome. He's doing that through the introduction of a range of new programs. In 2010, he was instrumental in introducing healthcare homes, which has now become a national program in New Zealand. Pinnacle has also developed a primary care secure cloud system called Xcrania, a fully supported cloud system for primary healthcare providers. John now leads Ventures for the Pinnacle Group, which is managing innovative thinking for Pinnacle. Ventures manages all the ownership and management of the practices owned within the Pinnacle Group and is also establishing new partnership with industries outside the health sector to explore and develop new models and approaches for primary care. And this is about better meeting changing consumer and patient needs. I am sure John can tell us about these initiatives and much more. He is on the cutting edge of primary health care. Please welcome John.
Thanks, Leanne, and kia ora, and good morning, everyone. Thanks for the comments around the Christchurch tragedy. It has been interesting being away and having to deal with that from afar, and I think going home tonight's going to be interesting as well. Getting back into the country, I think, is going to be a little bit different. But anyway, look, it's a real pleasure to be here. You're probably going, who the hell is John, and what's this got to do with general practice in Victoria? But I'll try and explain that, but a few credentials. If you go back to 1969, the day that Neil Armstrong landed on the moon, that was the day that I was conceived by the rock pool in Palm Beach in North Sydney. And so that kind of makes me Australian, I think. And then my mother, who was only 16 at the time, was shipped back to New Zealand at that point, which was the kind of trans-Tasman era of adoption, and dropped off at the hospital in labour and had me, and then was back at school in Avalon in Sydney a week later. So I grew up in New Zealand, not knowing who my parents were. I got to meet my mother at 20, and she now lives in Hobart. And at one point I thought Jimmy Barnes was my father because he was looking for a lost love child. So I thought that got to be Dad. So I bought all the albums, and perhaps the fact I couldn't sing should have been a giveaway. But anyway, he found his child and I didn't find Dad. But I've now since met my father, who lives in Byron Bay. So I'm lucky enough that I've got sort of multiple families. So I spend every Easter in Byron with my father's family, and my kids and family enjoy time there. And then we spend time down in Hobart with all the joy of Tasmania as well. So yeah, I like to think I've got a bit of Australia kind of in me, even if I live in New Zealand. Look, as Leanne said, I'm from Pinnacle. Now, Pinnacle is one of the larger, older general practice networks in New Zealand. So we've just turned 30. We're completely owned by about 400 GPs. And while we contract with the government and have relationships with, the local hospitals and other agencies, we are GP owned. And that means we get to sit and watch the politics that go on around us, and we're not as affected by some of those changes as perhaps other organisations which are government kind of constructs. And that's an important thing to remember, because I'll talk about some of the stuff that we've been able to do as a GP network over the time. It's always these fearful moments when you push the button and nothing happens. Oh, there we go. So look, I just wanted to touch on and provide a little bit of context for what's kind of going on around us. I think, look, there's a lot of change that's kind of going on, and that change is meaning that, what we do on a day-to-day basis as primary care providers is also changing. The way that technology is disrupting the way we communicate, the way that we understand what's going on in our lives, means that as providers, we need to start thinking a little bit differently about how we deliver services as well. There's a whole range of devices that are now sort of becoming attached to people, and that data is starting to be fed in. And while we're all a little sceptical about the use of that data, more and more, I guess, patients and consumers are using that data to make more and more decisions around what they do on a daily basis, around what they eat, around how they exercise. And they're even starting to use genetic material, from online purchases of that type of information to also influence their thinking about choices they're making around medications or even around services that we might be suggesting that they uptake to deal with issues. So we need to get a kind of good sense of that as well. Love it when the IT works, yep. There's a whole range of sensors that are going to become more and more available to us to manage and help us with people with long-term kind of chronic conditions. I recently travelled through the States with a colleague who's got really quite complex type 1 diabetes, and he had a range of new sensors that he plugged us all into. So all of our phones had access to his information, and we all played a part in helping him manage. Particularly as we had a couple of long road trips as we drove up from Vegas up into the Sacramento kind of area. It meant that we were all aware what was kind of going on. That was a different experience for us, where it sort of became a car that was responsible for the person in it in a different kind of way. We could monitor him remotely through our phones, but it also meant that we had a lot more active discussion around how that was affecting him as we were going. I think we can all remember when we had our first child, and I know that for me and my wife, we took home our first son, James, and I think within about 20 minutes we'd diagnosed him with some chronic respiratory illness, and we had paediatric textbooks all over the floor trying to work out what it was. But, this is a pair of boots now that a parent or a health provider can attach to a child, and it provides a whole lot of live kind of information. I don't know whether that's a good thing, but people will be starting to buy these things and use that information and be wanting to come and talk to us about what that information might mean. So we need to be better equipped to understand how to respond to some of that. I particularly like these. These are the electronic clothes that make you look really slim because they're black. I'm waiting for my size to arrive. But, these are the new kind of sports things which have got sensors through them. They're even measuring the amount of sweat that people are putting out and gathering information from that so that people can adjust their training and so forth as they go about. And then these things is what my daughter refers to as the orgasm pants. But these are the assisted clothing, which actually fire small shocks of electricity through to fire up some of the muscles, and they're starting to assist people in movement. So I think, we're going to move away from some of the more mechanical kind of supports that are available to people to less intrusive, but potentially quite enhancing different ways of kind of looking at things. So I think we need to constantly take into account, while we might be in the clinic doing the same thing every day, day in, day out, most of our patients are living in a world where there's a lot of stuff that's changing around them. And we need to think about what their experience might be as they come into general practice that might not seem to be feeling like it's moving at the same rate as some of the other stuff that's going on around them in their lives. But also we need to make sure that we're equipped to know what to do when a patient turns up with a pharmacogenomic report that actually says that they're an ultra-fast metabolizer for a particular drug that we've been using to treat them, and we don't actually understand what they're talking about. So, we need to make sure that we're keeping up and thinking with what's going on. But to do that, we really need to create a little bit more space in our day, because I don't know about you guys, but for most of us, we just don't have the time. We're running, and we're running really hard, and it feels like we're running faster and faster all the time. So I guess what I was trying to sort of point out to this with all of those kind of examples is that the health sector, in particular, the way that clinical services are provided to patients, is probably not as advanced as the rest of the world that we live in terms of changing the consumer or the patient kind of experience. And I think, last night, just with the Christchurch tragedy taking place, I was confronted with two things. I was sitting at dinner and my WhatsApp thing buzzed, and someone had shared with me a video from inside one of the mosques after the shooting. I didn't actually know what it was. When I clicked on it and opened it up, it just looked like a video. And the thing that really struck me was just how graphic it was, and I didn't turn it off because I was kind of sucked into trying to understand what it was. But I think that in itself, and my own response, which was, this is like some crazy movie that I've kind of been watching, is that more and more young people and older people are being exposed to more and more chronic violence and graphic kind of images. And that's starting to have a massive impact on mental health. The second video that came through was someone sharing the video from the shooter himself, that it had, on a bodysuit. And to think that someone would go to the effort of sharing that and making it available. And it's been interesting on the New Zealand media, less so on the Australian media this morning, the debates about who's got the responsibility to limit access to that thing. Should YouTube or Facebook or those other kind of agencies be cutting and pulling this information more rapidly? Interesting question. My point, though, really is, as health providers, we can't pretend that we're isolated from this electronic and changing world. Our patients are being pushed around by it and are using it on a daily kind of basis. So look, that's the kind of world we live in. And I guess the summary of that is patients are becoming more discerning. They have more information when they come in, and that's changing the relationship that we have in some cases with our patients, because they often will have more information than we have initially, and they also have access to a really broad range of ideas on how to treat different things, which can make it kind of challenging to navigate discussions with them. It also means that they're in a world where actually taking what the New Zealand and I think the Australian systems have often put up, and society has said, look, we should be grateful. This is the public health system. It's a great system. It's taxpayer funded largely, which means that it's cost effective and it's accessible. So we shouldn't really question it too much. And I think because people were becoming more consumer-like, that's not the position that they're starting to hold. So I think more and more we're seeing, particularly in New Zealand, we're seeing the number of complaints that are being made around care that's being provided are going up, and they're becoming more complex. They're not just, he was a grumpy bugger who didn't listen to what I said. They're often much, much more detailed kind of complaints around the kind of treatment that was or wasn't offered. And I think that's a response to that. The other thing, though, and the opportunity that I think we need to kind of look at is that because of that technology, we could be behaving differently as groups of providers. We don't need to be as isolated as we have been, because we're so busy and we're in a room and we're seeing patients on a kind of treadmill, busy kind of day. We often don't have the opportunity to share the information with other providers around us in a real kind of setting. The technology that's there is now starting to enable us to do that quite differently. And I'll talk a little bit about how that's kind of worked for us. So look, just to summarise it, I think technology is really changing and starting to put pressure on people's expectations. It's going to put pressure on us, as we need to understand what our patients understand, but also what tools are available. Consumerism is changing people's expectations around the experience of what primary care is about. And so maybe, the 15-minute appointment doesn't feel like a great value proposition anymore to patients. And perhaps the 15 minutes at a time that's really convenient for me, but isn't really very convenient for them, isn't a great value proposition. Or sitting around in a waiting room and having to sit there for 40 to 50 minutes after the allocated time that you were meant to be having the appointment isn't a great value proposition. So we have certainly started to feel the kickback from some of those kind of things. People are managing themselves much more. They have a lot more information available to them, and they're starting to use a lot of technology to kind of gather that. Now, we know that that's when people are relatively well. We know when people develop chronic illnesses or need more intervention, that the relationship changes, but it can often mean that our days are clogged up dealing with stuff that maybe doesn't require that kind of intensive time, and that we could be dealing with differently if we'd organised ourselves differently. We've got our changing demographics. We've got our ageing population, and we've now got parts of New Zealand where it's equalised. We have as many people out of work, either retired or kids, as there are in work, which is the first time that's happened for us, and that's starting to put great pressure on our ability to respond. We just don't have supply around that. We're also starting to experience, and I think, there's some really public global examples of this with things like GP at Hand or Babylon or Health Tap, a lot of those kind of virtual kind of services that are popping up in other parts of the world. Babylon and GP at Hand in London, for example, have really disrupted the traditional relationship that almost a whole generation of people are having with their GPs. So we're seeing a younger cohort of people who are choosing not to enroll or register with a GP, and they're just choosing to buy an interaction off a smartphone to treat things. Now, when they have major life events, children, or they develop chronic conditions, of course they want that longer ongoing relationship with a provider. But for the New Zealand system, the way that we're funded, we kind of have to rely on a lifelong relationship, and we have to rely on a relationship with not just sick people, but also well people for things to be sustainable. So we're seeing those other providers coming in. We're also seeing corporates coming in, and corporates often have a different kind of view on how services need to be run. They have shareholders that are often looking for return, which is kind of different than the tension that would be sitting in a practice where sometimes you make a call based on what what is right for the patient, but perhaps wouldn't be the same kind of call you'd make if it was just purely a business. So I think there's a range of things that are kind of hitting us and starting to present some challenge. Look, the other thing for us is that we started to do a little bit of looking. So we are based in the middle part of the North Island. We go from just south of Auckland to just south of Taupo, and then we go to New Plymouth and out to Gisborne. So we have about 500,000 patients. We have around 400 GPs. And what we did is we took our population and we aged it. And we said, okay, well, what's going to happen to utilisation? We know how the different age groups utilise our services now. Remembering that we've got a capitated environment, and so we have enrolled patients, and so we know exactly who our patients are. We did that, and we could see that between 2014 and 2020, we were going to see a 55% increase in demand. And that was just putting over simple things like chronic condition levels and ageing the population at the same kind of time. That was going to leave us, we started out in 2014 providing about 1.7 million GP consults, and with that increase we were going to see that was going to grow to the need to be able to provide 2.6 million GP consults if we just kept on doing what we were doing. Sorry, can we just go back a slide? Should be one more. Look, what that was meant to show was just the shortfall that we were going to end up with. So that essentially as a network, we're all either going to have to work twice as hard, or we just weren't going to be able to service the same number of patients that we kind of had. And because we're also a network that is predominantly rural, we have most of our patients living in small communities of 10,000 people or less. The risk that we also face is that we just see an exit of providers. It's too hard, I can't keep up, I'm getting burnt out, I leave. And of course, what that then triggers across the system is more people end up in hospital inappropriately, and the system just ends up costing more and more. The other thing that's kind of happened for us is that our workforce has changed significantly. So in 2006, 70% of our GPs were owner-operators. So they had a stake in the practice that they were working in. When we got to 2009, that had dropped to about 61%. 2013, it had dropped to 50%. 2018, it had dropped to 43%. And we're now under that figure, and we're only at about 35% of our workforce now have a stake. So that means we've almost flipped entirely. So the bulk of our workforce is now sessionally employed, and it's predominantly female. So that's considerably changing the way that the practices operate. Now, funnily, the practices, however, still remain owned largely by males. And so they're fondly referred to as the GOMs, the grumpy old men, who are the ones that feel like they're left having to do the on-call because the sessional people don't want to do on-call or are unavailable to do on-call. And they're also left having to make a lot more decisions, where when there are a lot more owners involved, there was a lot more discussion about how we were going to respond to things. And so that's fundamentally changed how our network's operating. And it's put a lot of pressure in some of the kind of areas that we kind of work in. So look, we kind of spent some time looking around the world to see what other people were doing, because we thought, well, this isn't a unique challenge. This is a challenge that health systems all across the globe are kind of facing. We spent a lot of time looking at what we actually do in primary care. And while it just sometimes feels like you're doing 30 to 35 consults a day, if you break those consults down, we discovered that we had a range of things that we were doing. We have the unplanned kind of people waking up in the morning and feeling sick and wanting to come in and deal with things urgently. We have the whole proactive thing where we're trying to do the screening and we're trying to manage the chronic conditions and we're trying to do the immunisations. And then we have the routine and the preventative kind of things. Plus, we have to run a business in there. So we kind of broke it all down, mapped it all out, and thought about the things that we needed to do a little bit different. We also, as I said, we looked around at what other people were doing, and there was interesting stuff everywhere that we went, but the place that we ended up going back to, and we've continued to go back to, was Seattle. We developed a relationship with what was then called Group Health. It's now been consumed by Kaiser. But Group Health at that point was a network of about 500,000 patients. It's consumer-owned, or was consumer-owned and consumer-governed, and it had roughly the same number of GPs and providers as we had. And they were embarking on what they was referring to at their point in time as the medical home. And while it's the States, we had a view that, everyone in the States gets an MRI for, anything. We discovered that actually, no, they're human, and most of the treatment pathways that they were using were pretty similar to what we did. But what we did discover that they were doing differently was that they had different partners available to them. So in Seattle, you've got big companies like Microsoft, Amazon, Boeing, and they'd partnered up with some of those organisations. And in fact, what they'd done is they'd used the lean practitioners from the Boeing factory who'd taken the assembly time for a 737 down from 32 days to 24 days, simply by reorganising the way that the carcass of the plane moves through the factory. And they took those process engineers and they brought them into primary care and they process mapped everything that was happening in primary care. So we replicated that. So we brought some of these engineers over. And what was really interesting about these engineers is that they're pretty unemotional types. So, health's often quite an emotive storytelling environment where often the data's a bit vague in primary care, but, we've got a reason why we do that. And, my population's very special. You don't understand how special my patients are. These engineers were really good at saying, well, really, can you show me why they're like that? Or why do you do that? And, well, we've done that because, Dr. Smith was here and he always did that. Yeah, but why did Dr. Smith do that? And they just cut through a whole lot of that kind of stuff. And so what we ended up with was, I'm not expecting you to understand this, but we ended up process mapping a patient as they move through a clinic and for a regular kind of consult. And we started to identify the things that we needed to do different to change that experience and to use the resources that we had available to us really differently. And so if you look at some of those yellow starburst things, there's things like integrated clinical pharmacists, because we broke down a whole lot of the issues around medication management. And we broke down the fact that actually, the GP's not that great at managing some of those complex medical things, but clinical pharmacists are bloody amazing. Now, that was a little bit challenging for a few people in the room, but, we broke it down, we looked at the data, we started to look at the outcome, and that was the kind of collective position we came to. There's a thing there that says implement a patient access centre. Now, implementing a patient access centre was because we started to look at what happens when people want to access general practice. The first thing they usually do in New Zealand is ring and ask for an appointment. And we have the most lowly trained and lowly paid person answering the phone, giving away the most scarce resource we have, which is an appointment with a GP, with no kind of discussion really about is that the most appropriate clinical response. So we had identified that the best thing to do was to get the patient to talk to the doctor before a consult was issued. Now, that comes with a whole lot of complexities, which I'll talk about, but that's been one of the massive game changers that we've kind of had in there. We also had in there, things like change the way that you use the rooms. We've talked about patient portals, because one of the other things we saw was actually we need to give patients their own records. And we also need to get them online so that they can communicate to us electronically, so that they don't always have to physically come in and see us, because that's actually the least efficient way of seeing a patient. And we also went through and we identified that, and we did this with heaps of clinics and heaps of doctors and heaps of patients. And we identified about 68% of the visits that we were running didn't require a physical interaction. It was just because that's what we'd done, because that's what the funding had really taught us to do, rather than what was clinically kind of required. So look, we had a very structured approach to it. First of all, we looked at our buildings. How do we use our buildings? We discovered that a lot of the rooms in our practices, some of the rooms were only being used at 60%, because that's John's room, and I'm not going into John's room because it's a pigsty, I can never find what I need, and it smells funny. And so John's room wasn't used unless John was there. But often primary care is in a position where it's saying we can't do more because we don't have any more physical space. So these engineers really went through, they gave us stickers, and we had to touch everything that we touched in the room. And, those collections of magazines from the 60s and, some of the other things that really just gather dust became really apparent were unnecessary for good care for patients. And so we had to go at taking them out. And one small rural practice, we had 6 horse floats of stuff that we took out. We broke a tow bar on the back of a car with one of the removal kind of things. And so that left us with a very bare feeling practice, which didn't feel quite right either. So we had to kind of reorganise that to make it feel more friendly. But we also decided that actually having a GP sitting in a room that's really designed for seeing a patient when they're not seeing a patient is a kind of crazy thing to do as well, because you could have another clinician in that space using that space, and you could have the GP sitting somewhere else. But of course, John wants to sit in John's room because he knows where all his forms are, and it's his computer, and he's got his shortcut keys, and, so no, that's my room, thanks very much. So we had to go through this kind of really traumatic divorce for people in their rooms. And so we moved GPs into shared spaces, imagine that, where if they weren't seeing patients, and I'll explain why they weren't seeing patients in a minute, they sat in a room with other GPs. Oh my God, I can't sit in a room with John, he talks too much. And I'm not going to be able to think. How am I going to do my paperwork if I'm in another room with another doctor? I can't ring a patient, it's a breach of confidentiality, et cetera, et cetera. So we had to go through quite a lot of traumatic kind of stuff. In some clinics, it was really funny. We moved things around. Well, it was kind of funny afterwards. We moved things around, and some of the doctors came back in the middle of the night and stuck their names back on the doors and moved things around so that they could get back into their room. One had a work-safe kind of consult where, she got, someone to come in and say, oh, it has to be a certain chair and it has to be organised in a particular way. That has to be my room. I can't safely practice in another room. So people went to massive extremes to kind of fight the change, so to speak. But the physical change became really important. We also, as you can see there, we mapped how much we moved patients around. So a patient came in, and then often we moved them around the clinic because the providers were in different places in the clinic. Or how often our nursing workforce had to move around because they all shared one computer at the back of the clinic. They didn't have their own kind of space in which they had their own IT. So that was one thing, physical rearrangement. The other thing is that we reorganised the day. So if I take one practice like North Care, so about 15,000 patients, about 8 doctors, on average people were seeing 28 patients a day. We said, right, we're going to drop the number of face-to-face consultations you have on a daily basis from 28 to 18. And everyone went, yeah, right, who's going to pay me? So there's a whole discussion we had to have about, well, we're going to do some different stuff with funding. But basically they said, well, what am I going to do with all the time I've got? And we said, well, we're going to get you to do a number of things. So in the morning, when your patients are ringing up for appointments, we're going to get you to talk to them. So that was really funny. So what we had patients ringing up thinking they were going to get Pam from the front desk, And, Pam would answer the phone and say, I'd like to make an appointment with John. And they'd say, hang on a minute, and they'd put them through to John. And then John would go, hello, and the patient would go, sorry, doctor, I didn't mean to ring you. I'm just trying to get an appointment with you. And then the doctor would panic and say, how about you come in at 10 o'clock and then hang up? So it was the most expensive and inefficient reception service ever known to mankind that we managed to establish there. So we had to do a lot of coaching with people. But what we now have, we have 50% of people who are ringing and asking for a same-day acute appointment we are treating safely, and we've been doing this now for 6 years, safely over the phone. Patients love it. They don't have to come in. They don't have to pay in the way that they've paid in the past. And it means that the GPs are not just getting double or triple booked and running as fast as they can. So that was the first thing we said. You need to do some clinical triage in the morning with your own patients. And, we had to put a lot of training in place because there were a lot of the docs just didn't feel confident in going back to triaging people over the phone. And of course, there's a paper that's come out of the UK that, the clinical outcomes from that are terrible and people end up coming back later in the week and all the rest of it. So there was a lot of that, people finding evidence, once again, not to make any change. But what we've got is really clear evidence is that's made a massive change. The second thing we said to them is, we're going to give you time throughout the day where you need to do a number of things. You need to spend time emailing your patients. So we set up some secure portals with patients, and we started encouraging GPs as part of their care plans with some of their more complex patients to negotiate a different kind of relationship that didn't involve the patient needing to come back in all the time, but could move to an electronic discussion. We also moved to saying, let's have planned phone consultations. So sometimes in the morning, when you did that triage, you thought, actually, I might need a little bit more time, but I still don't think you need to come in. I don't have time now, but can we book another point in the day and I'll ring you back? Now, one of our docs, who's also called John, had his first time he did that, he rang up, and it was an elderly patient who was so excited that the doctor was ringing that she'd invited her 2 neighbours over. And so we ended up having this group consult over the phone, which he found quite intimidating. But what it's done is it's given the GPs a whole lot of other tools in their toolbox. They don't just have to do face-to-face consultations now. They have other things that they can do. Now, to make that happen, we had to make patient information available to them. So we had to say to patients, here's your record, and we had to say, here's my notes. Now, that was like suggesting a Michael Jackson maneuver on small children, I think. We just got massive kickback. People were like, you can't do that. It's medically legal. You just can't do that. We can't. No, they're my notes. No one else can see them. They're not designed for that. And of course, the matter of the fact is they're not just our notes. They're the patient's notes. It's their health record. And so we had to go through quite a long, drawn out, and we had big, long debates around that. But in the end, we agreed to open notes up from a particular point in time. We weren't going to go back in history because there were a whole lot of other providers that had added to that record that we couldn't be really held to account for, or we didn't even know what was there. But we said from this date moving forward, we'll make those records available. We'd also said to the patients, we'll give you the ability to email your doctor. So the other thing was, well, I'm just going to get bombed with emails. All I'll do is answer emails, and you want me to do that on top of my busy day. We're like, well, no. Remember, we're reorganising your day, so you've now got some protected slots in which you can undertake some email. And 2, you only let people email you as part of an agreed plan. It's not an acute service. So you're not sitting there in the morning responding to an email saying, I've got a sore knee, or, it's got to be part of an agreed kind of care plan. And so in the 8 years that we've been doing that, we've had 2 examples across all those patients where it's gone a bit haywire, and the doctor or someone else has had to step in and say, no, look, we're going to turn this email off because this isn't working. So 2 examples. So I can give you hundreds of GPs who now, this is a tool they use every day to manage their demand differently who will tell you, despite all the concerns and fear that they had at the start, that it's different, that hasn't eventuated. This thing's like goes to sleep. Yes, so we gave them portals. And that's what a portal looks like for a patient. So there's a whole lot of information that they can get to. They can book different types of appointment online, which that in itself was a little bit troubling, and we had to bring that in a staged kind of way. They can see their medications. They can order repeat scripts. They can see their results after they've been checked by the GP, who then pushes them into the portals. So we built this. This wasn't built, you've got your My Health Record kind of thing going on. This was us building this to help us manage demand and change the way that our relationship kind of worked for our patients. We can drop in a whole lot of treatment plans. We can drop in lifestyle advice around diets and other kind of things. You drag and drop stuff into the portal from the record. We've also can do video consults. So we don't need a Babylon. We've kind of built it in as part of our own kind of ability. Now, to be fair, the video consult kind of thing is still, we're not sure about it. It's a bit gimmicky, and people spend a lot of time doing their hair when you're talking to them, and that's my wife. But you all know as you Skype and Zoom with people that sometimes it can be an awkward kind of medium to kind of get used to. But we've found, like for our farming communities, they love this because they can ring up and then go, yeah, there's not too much blood, but do I need to come in? Well, yeah, there's a bone sticking out. You really do need to come in. Joking aside, it's given them a different way of communicating. And for them, it means they don't have to travel the kind of distances that they do, and that they can, even ongoing wound management, they can share that kind of information, and patients can, self-manage stuff in a different kind of way. Really love the way this goes to sleep. So the call management, I'll just spend a little bit of time talking about that because it's quite important. I think I've got another. Oh no. So with call management, what we discovered is that we got the guys from the telecommunication companies to come in and say, well, what does it look like on a busy morning in our practice? We've got 5 lines, and they're really expensive, all those lines. How's it going when patients are trying to ring in? And we discovered, and this is a similar number has gone around all the practices, that on average, 25% of people who are trying to get in to make an appointment can't even get the phone answered. And they on average try 5 times, and then often they'll just go somewhere else. And the somewhere else in some of the urban areas is they'll go to ED, or they'll go to one of the acute kind of centres. So what we've now got is a centralised call centre. We've moved that frontline reception service away from all of those practices, and those calls are now answered. The patient doesn't know that. Well, they do know it because we've told them, but the experience they have is no different. It's based in one of our offices, and we've got teams of people that sit in the call centre who are now extended members of those practice teams. So they regularly go and visit them face to face. They know all the doctors, they know the nurses, they know the other staff that are there. They're just in a different physical kind of space. And as a result of that, our average call abandonment rate is 3%. So we've gone from mid-20s to 3%. Now that in itself has caused a problem because it's increased our demand, because we're answering the phone more efficiently now. And so we've got more people who are wanting to kind of make contact with the team. So we didn't think about that when we started that, and that introduced a whole lot of issues that we kind of had to work through as well, which resulted in us changing the schedules around so more doctors were available to take some of the calls and do some of the triage. But medium to long term, the practices that are on that compared to the practices that don't have that have no waiting times. We've managed the demand in a way, whereas the practices that are not using that, some of them have still got, a week to 2 week kind of waiting time to get in to see your own kind of GP. So look, I guess what we saw, and this is partly why I'm going through all of this is because when we heard that Australia was doing the healthcare home, we were quite excited. And in fact, a couple of us went to Canberra. We were asked to go give advice to some of the committees there. And when we looked at what they were going to do under the banner of healthcare home, we were like, well, it's none of this. It's a chronic condition management program. And for us, healthcare home is about helping general practice reorganise itself so that it's in a better state to be able to work on and work into the future. So we knew that the traditional model was not right for everyone. It was very focused on a building and it was very focused on face-to-face consultations. We know, particularly for Māori, that we don't have or didn't have the same kind of health outcomes from general practice that we were getting from non-Māori. We knew from talking to patients that the experience with general practice is that care from the GP into other providers is often a bit fragmented. They see the GP will then refer them to someone, and then it all goes to buggery from there, because everyone they have to go and see, they have to retell their story, they have to be re-examined, they have to, repass on the clinical kind of information. So we needed to address that. We knew that there was a lot of isolation, even within the clinic. So that conversation where, man, I haven't seen you all week. It's been one of those weeks, hasn't it? And literally, people were not seeing their colleagues. They went into their room, they were there all day, and then they went home. And they came back the next day, and the next day. And that's what it was like. And that's where we're starting to see burnout starting to occur as people become isolated. And we could also see that the kind of complaints that were coming through. So by moving the GPs into some of those shared spaces, they're all saying, after they got over the fact that John talks a lot, that they have a better work environment. They have better access to colleagues. They're doing more kind of collective case management. And often they're getting off a phone, or as they're writing an email, they're asking one of their colleagues while they're sitting there what they would do with a particular kind of challenging kind of case. It's fundamentally changed the game for those people in those clinics. So it's not just us. So while we might have been a bit mad when we started, it's now happening right across New Zealand. And so there's about 150 practices and there's over 1 million patients that are now in there. And that's just a constantly growing thing. The way you go about it, we've now built a range of requirements, and this always terrifies me because this is when you lose the hearts and minds and it becomes a bureaucratic kind of process. It's a bit like the college wants to, get you accredited for this or that. But we do have a framework, because what we don't want practices doing is saying, I'm a healthcare home, and all they've done is paint the waiting room, but they're doing nothing else different. There is fundamentally a lot of change that we introduce, and that introduction changes things. Now, you might say, but does it work? So the problem is that we all know that whenever you do something different, it's often really quite hard to prove that story. And it doesn't matter how you evaluate something, someone will find a reason why that evaluation wasn't right. It's like that mole game where you just keep hitting moles. So we've done multiple evaluations, but I think this one has been the best one at telling the story. So we took a group of practices, about 83,000 patients that were in our healthcare home, and we created a control group of the same number of patients in some high-performing traditional practices. And then we compared a number of things. At a high level, we could see ASH is avoidable sensible hospitalisation. So it's a measure of stuff that's turning up in ED that we could have managed in primary care. So it's a measure that we have consistently across New Zealand. And ED rates were much lower in the healthcare home sites, and they were much lower for the higher risk populations as well. We could see that, or the evaluators at EY could see that a significant proportion of the acute care was being dealt with differently in a community kind of setting. And particularly for Māori and elderly, we were seeing quite a different kind of outcome. So look, 62% of the people that were calling in and are asking for an appointment, we were managing without their need to come in for a face-to-face consultation. I talked about the triage. So here you can see that 95% of the patients who wanted a same-day appointment ended up either directly or having a callback from their own GP within 30 minutes of that appointment. And 60% of patients were able to talk to their own GP. And that in itself is getting more and more complex because of our part-time workforce. So, often a particular doc isn't there on a particular day. And you can see that 35% of them were managed with clinical advice or a virtual script. And, on average, we could see that was saving patients around 50 minutes by not having to come in and do that. And patients were really, really appreciative of that. I talked about that. So you can see the call abandonment rate is 3.84%. The average time to answer a call is 26 seconds opposed to minutes or days in some cases. And you can kind of see some of the numbers kind of on the side. If you're registered in a healthcare home practice, as opposed to our high-performing, traditionally organised general practices, there was a 20% less likelihood of you being admitted to hospital. Now, we standardised the kind of patients who were in all of those. So we took practices that were very similar. We didn't sort of, play a game where you took a well population and put it up against a really sick population. They were standardised. If you're over 65, you were 32% less likely to end up in ED. 32%. That's a big number, particularly when you look at the number of elderly people that are going to ED. If you were Māori, there was a 24% less likelihood you would go to ED. Now, for us in New Zealand, that's a massive number, and that's a massive difference, because what we traditionally see is Māori are just overrepresented in utilisation of acute care all the time. So that figure there, just alone, has been bloody amazing. You were 20% less likely to be admitted for unplanned care. So people were still going to hospital, but often it was deliberate because we had more time to do more complex workups and more deliberately refer to a specific specialty. So we also looked at the referrals, and we saw less general referrals and more specific referrals to specific specialties. So we saw a distinct increase with that. And one of the things that they discovered is that one of the biggest things that's had an impact on Māori is that 50% of Māori in the healthcare homes had a care plan or an active care plan in place around managing a chronic condition, compared to the traditional practices that were still actively trying to manage similar conditions but didn't have a formal care plan in place that the patient had access to on their portal or could share with others. And I mean, it's really been seen, and we still strongly believe that we think that's a massive contributor to why we were getting such a different swing. So yeah, there's a range of other things that they kind of picked up on, which I won't go through line by line. But what we're starting to see is by reorganising ourselves quite differently, by structuring the physical arrangements differently, by structuring the information differently and making it more available to patients, and through structuring the way that we use our day and our time differently, we're getting massively different results. Same workforce, same buildings, same money. I'll talk about the money in a bit, but very, very different outcomes. But to get from where we were to where we are took a massive amount of thinking and debate and change management. And I guess a lot of the docs who, particularly in the privately smaller owned practices, really didn't think it was going to make a difference, and they were highly skeptical. But a number of those are now the ones that are our best advocates, that are standing up and saying, my life is better. I've got more control of my day. I don't feel as stressed. And actually, I'm making slightly more money than I used to in the past. So it's kind of ended up being a bit of a triple whammy for them. The other thing that we've done is we've moved to grouping practices and getting them to work more collaboratively. And you'll see, like, this is becoming quite popular. The UK has just published a whole lot of stuff around the future of general practice that's picking up on the community health hub kind of model. But we're kind of creating these natural clumps of practices around the 30 to 50,000 kind of patient base. And we're starting to share services across those kind of practices. So as a GP's retiring, maybe we're saying, actually, across this group, let's not replace that GP. Let's collectively employ a clinical pharmacist. Or let's collectively, purchased or bring in some specialist support to sit and work privately in our system to manage our particular demographics. So, we've got diabetes, or we've got geriatrics, or we've got, different kind of mixture kind of going on. So in a place like Taupo, I don't know how many of you have been there, but around the Lake Taupo area, there's about 34,000 patients. And this is the kind of shared team that now sits and is jointly owned across 4 practices. And you'll see, particularly for this practice, the big struggle that they were having with their patients is quite a high percentage of Māori, a lot of obesity and diabetes kind of related kind of conditions. So what we've ended up with there is a whole lot of exercise kind of consultants really stepping in. You've got Shane in the middle, who was a patient. He lost 62 kilos, and then he's now become the lead. So he gets up in the morning, most mornings, as the truckies from all the forestry change shift at about 5:30 in the morning. He meets them, takes the guys coming off the shift and takes them down to the local pool and runs an exercise program. And then what he then does is, when he gets that group to a particular point, he invites the GP to come to them. And then what they end up doing is they run group consults. So we've now implementing consistently group consultations across groups of kind of patients. And so that's enabling us to do more with less as well. And so we've kind of oversubscribed in a couple of areas now where patients have kind of come in. And, there's great stories about that, where you get half a COPT group coming in, half the group haven't had their flu jab, kind of get convinced by the other half of the patients that they need to get their flu jab. The clinicians in the room don't even have to do anything. It's patient self-management kind of at its best. But it's a different view of what general practice could look like. It's not just a GP in a room or a box. It's actually a whole care team built around a patient kind of population. And I guess, look, the Commonwealth Fund and others are starting to publish a lot of kind of interesting information about how that kind of works. So look, we've got a few other things that are kind of coming that are going to help with that. I've talked about the group consultation stuff. We're doing a lot of stuff around retail collaboration in a lot of our rural communities. The big buildings in town, we have the warehouse, I guess it's like Big W or the equivalent for you, or supermarkets. And so supermarkets for us are becoming big health players. The pharmacies are popping up in them. They're incentivizing patients by reducing co-payments to pick up pharmaceuticals or scripts. And so we're starting to partner with those retail groups to set up clinics with them. So if I take a community like Tokoroa, 60% Māori, forestry community, there's a big mill. The health services traditional practice is shut at 6:30. Most of the people don't come off shift till 6. And so when most people really need to access care, there's no one there. So the rural ED gets a big hammering. But the thing that is open in town is the warehouse, and the warehouse is open till 9:30. So what we're now working at doing is putting some clinics into the warehouse kind of setting rather than running the clinic separately. The warehouse is kind of interested because it's changing some of their foot traffic kind of patterns. And the community there have loved it because all of a sudden mum can go in and do some things for mum while the kids play in the Lego aisle, which is a better place than the waiting room at the clinic. Or she often won't go to the clinic because there's nowhere to put the kids. So, there's some stuff there we haven't worked out, but there's some stuff that's starting to prove and feeling quite exciting. We're certainly increasing our number of community health workers. We're recently up in Boston, and there's Cambridge Medical Group up in Boston. They're doing similar things. So we're in a practice there at a morning huddle, and there was one doctor, 3,500 patients, and 7 community workers, and that's how that practice is organised. And so most of the care they're providing for that practice is mental health, it's social, related kind of issues around housing and so forth. And the medical kind of things are just being dealt with by a very different kind of approach. And that was really funny, that group as well, because they introduced me to a new code that I'd never heard of before. In the huddle, they were talking about this particular patient who was suffering from TI. They went on and on and on about TI, and we're like, well, what's this TI thing? And it was Trump issues. So patients coming in stressed out about what Trump had tweeted that day, and that was causing stress for patients. And we were like, you're kidding? No, there's a whole cohort of elderly people who TI is a major and a real kind of clinical kind of condition that we're having to manage. It was, geez, imagine that. Right. Okay, so look, I've just about finished. So the things that have made it work is that, if you try and do this at just a practice level, it's just too hard. You're too busy. How do you stop? How do you get everyone involved? How do you facilitate that change? So you need to do it. We've done it because we've got a network that sits around us. We really needed leadership. So we needed people who really believed and had seen the change. So we actually, a couple of times, loaded up some planes and took people to Seattle because we had a lot of cynical clinicians, and they had to get in there and they had to scratch and sniff and poke around and actually understand, sitting through consults with people that were running the model, that people weren't dying as a result of it, and people were actually having a better experience. And then they came back and they became the advocates. We had to invest in backfilling people's clinical time. So we had to take 1/10 to 2/10 of a clinical leader in each practice out, fund them to be free so that they could start to facilitate the change kind of within their practice. We really had to argue with the funders, because, we're not quite as restricted as you guys are, where you've got everything kind of fee for service largely. We were capitated, but even the way that we used our capitation funding, we had to really break a whole lot of the rules. And so we had to have a big conversation with the funder, which was, we will get these outcomes if you stop worrying about the inputs. And that took, we had to have economists, we had to have some big brains in the room, and we had to put up a big case. And, the numbers that we're now getting back are what's kind of coming through. So we're now starting to see our government and our funders recognising that the traditional way of funding general practice will get you the traditional response. If you've got groups who are prepared to do things differently, and you put some of that flexibility up around the money, you will get different kind of outcomes. The shared IT system, I can't emphasise that enough. And look, your PMS systems, which I've seen most of them, they're very skinny and they're very isolated. Essentially, they're built for claiming. You really need systems that are built to help transfer and push information for patients and providers around. We couldn't find one off the shelf. We had medtech for many years, which had done us well, but it couldn't do a lot of the things that we did, and we ended up having to build our own. I wouldn't recommend you do that, because that's just about killed us. I used to have a whole lot of hair and be really skinny. It was a really complex thing to kind of do. We're in a better position, but there's different products that are now available. You need to be able to share information. You need to be able to give your patients their notes. You need to be able to transfer information. Australia's got the whole kind of My Health thing. It's an opportunity, but it just doesn't feel like general practice is in the driving seat. And I'd really suggest that general practice needs to gain some control about, because it's such a key point in terms of where patients hit the system first, how you use that information kind of transfer. And look, you really need to believe that, general practice is the most important part of the health system. It's the cornerstone. It's where 90% of the care in the structured health system often starts. It isn't where it all happens, but it is often where it starts. And if we just keep doing what we've always done, you're not going to be able to see all your patients. The demand is going to outstrip your ability to supply as the population ages and as you get older. And the next generation of GPs that are coming through are not as interested in working in the kind of model that's worked so well for the last 30 or 40 years. So there is a whole lot of reason to think about doing it differently. You could wait for a government to prescribe it, which would be a guaranteed disaster because they'd get it wrong. Or you could grasp it yourself and say, how can we start to design a new system for ourselves and then sell it back to the government? And I guess that's what we've done as an organisation, and it's now, for us, it's moving across the country. And I think for Australia, there's a massive opportunity for you guys as GP networks to really kind of grab that kind of baton and run with it as well. So I'll stop there. I hope that's kind of been interesting. So thank you.
Thank you very much. And, what a reminder of the broader context of technology and consumer empowerment that's increasingly impacting on the work. You've really made us think. And I'm looking forward to the discussions today that have been prompted by your work. And we do get that it's taken a while and there is grey hair involved. Congratulations and well done for your change process. Please thank John again. Can I also thank those who've been watching the live stream? We understand that it worked, which is good. And it'll now conclude, and any feedback from people who've been on the live stream is most welcome as we try and improve that technology so that we can create our platform. John's talk will be available on our learning management system at the PHN, so you're most welcome to have another look at that when you need some inspiration thinking about your practices. Before we get down to business of the